Welcome everyone to our webinar, Nutrition and Frailty Screening, presented by the Fall Prevention Community of Practice in partnership with the Nutrition Community of Practice. My name is Lindsay Toth, and I am the Project Coordinator at the Ontario Neurotrauma Foundation. ONF sponsors Loop and the Community of Practice on Fall Prevention. Marguerite Thomas also joins us on the line today. Marguerite is the coordinator of the Fall Prevention Community of Practice and will be assisting with the webinar technology. Before we begin, I'm going to give you a quick rundown on the Level 3 web meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line. The visuals are provided through a web platform. The phone number for the conference line and the link for the web platform were sent to you by email after you registered for the webinar with Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box located on the left-hand side of your screen. Alternatively, you can email lindsay@onf.org. We will work with you to resolve technical issues as soon as possible. This webinar will contain opportunities for participation. There will be online polls, which you answer right on your screen, and a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, I will read those questions aloud to the group. If you would prefer to ask your question over the phone, we will provide the instructions to unmute your line during the Q&A. I would now like to introduce our presenters for today. Heather Keller is the Schlegel Research Chair in Nutrition and Aging at the University of Waterloo, and Celia Lohr is completing her PhD in the School of Public Health and Health Systems at the University of Waterloo. Heather and Celia, you may now unmute your lines and take it away.
Thanks very much, Lindsay. So welcome everyone. Today we're going to be talking about nutrition and frailty and trying to demonstrate for you the importance of looking for nutrition risk in community living seniors as we're trying to prevent falls in older adults. So we're trying to make the case that nutrition and frailty screening should be occurring for community living older adults in Canada. We're going to cover off what is nutrition risk and the prevalence of it in Canadian older adults. Talk about the overlap between risk and frailty and how nutrition can lead to falls. Then talk about the overlap between malnutrition, frailty, and sarcopenia, as well as ways we can mitigate this by doing nutrition risk screening and frailty screening. And so we'll finish up talking about implementing screening in the community. So first off, what are Canadians eating that are older adults? Basically, we know that they're not eating very well in terms of food groups and in terms of nutrients. And about 2/3 are not consuming 5 servings of vegetables and fruit a day. So this data comes from large surveys done over the last 20 or so years, and it's pretty consistent that we're seeing poor food intake in this segment of the population. So why does poor food intake occur for older adults? On the left-hand side of the slide, you see a variety of issues we know to be associated with being an older adult in Canada, and I'm sure you can think of a few other examples here or reasons why there might be risk factors for poor food intake. On the right-hand side, I've actually given some statistics from the CCHS Stats Canada 2008 survey. And you can see that there's a large proportion of older adults in Canada who have significant risk factors. For example, 42% are in the lowest income bracket, 62% report depression, and 46% report poor oral health. All of these things can obviously impact food intake in a variety of ways. So what is nutrition risk? It's basically the occurrence of risk factors that are known to impair food intake or affect nutrient utilization of the body. And so we can see a range of what we consider nutrition risk because it starts with these risk factors. As those risk factors impact food intake, we actually see low food intake in terms of key food groups and nutrients. Over time, if that nutrition risk continues, you start to see overt or physical signs of undernutrition, such as weight loss. Over time, we also know that can lead to significant malnutrition that can impair function and quality of life of older adults. We know that it's easier to improve nutritional risk, so it's important that we try to identify risk as soon as possible and put into place strategies and opportunities to improve food intake in older adults. It is commonly measured by looking at a variety of risk factors in older adults as well as food intake and sometimes weight change, either self-reported or actually measured. And often the tools that are used for nutrition risk screening in the community are self-administered. A variety of good tools are out there, and those that predict key outcomes like mortality, admission to hospital, other comorbidity situations are obviously better tools to be using. So what is malnutrition? I often get asked this question because it can seem somewhat of a difficult concept for people to get their head around. Essentially, we define it as an adequate intake of energy, macronutrients, or micronutrients. And if that intake is inadequate for a period of time and it leads to functional change, that is actually malnutrition. So we're seeing changes in the tissues of the body that could lead to muscle loss, weakness, immune function impairment, capacity for recovery, and cognition potentially being impaired. So it's the combination, not only low intake, but it's sustained low intake that leads to functional change in the body. Key as well is that malnutrition can be reversed with refeeding, whether it be a micronutrient or a macronutrient malnutrition. And that's key because sometimes wasting and loss of muscle mass look like other things as well and not just malnutrition. So we look at the prevalence of nutrition risk factors in Canada. The CCHS in 2008 used the abbreviated version of a tool called SCREEN2, and it was published by Ramage, Moran, and Garrett in 2013. And I've just listed for you here some of the key risk factors. So 34%, or about a third of Canadians in that sample, which was quite a large number of older adults, over 15,000 I believe, in Canada, were at nutrition risk. And we can see some of the components of risk that were identified in this group. For example, 52% reported cooking difficulties, 42% reported eating alone, 26% reported swallowing problems, and 37% identified low fruit or vegetable intake. This was just the abbreviated version of SCREEN, which is 8 items. On the next slide, I'm showing you the longer version in terms of risk factors in a more vulnerable group of older adults. One, to show you the difference in prevalence of nutrition risk, but also that the food intake factors or items on the tool have a higher prevalence in this vulnerable population. So you can see that this study was actually done in 2003, and it was a large number of older adults attached to home care services in southwestern Ontario. We found about 44% to be at nutrition risk, 22% reported weight loss, and as you can see, food intake was actually impaired much more so than the CCHS sample, with almost half having low fruit and vegetable intake and 1 in 5 having low milk product intake. So what we're trying to show you here is that nutrition risk is prevalent, and it will be more prevalent, of course, in more vulnerable populations that you're dealing with. You'll also see, though, that you'll see risk factors for food intake being quite common, but not necessarily is that translating into low food intake for all residents. As a person becomes, older adults. I do work in long-term care, and I had residents on my mind today. And so you can see that risk factors can be prevalent, but don't always translate right over into food intake for older adults. But here, this vulnerable group of older adults, it does, and we're seeing that impact on their food intake and potentially on other aspects like their weight. So what is the problem with nutrition risk in the community? Why should we even be concerned with this? Using tools like SCREEN2, we've identified that mortality is much more prevalent in older adults in Canada when they have nutrition risk. So one study was done out west, looking at older adults specifically, and the 5-year mortality for those who were at nutrition risk was higher. Similarly, in the work that I had done in southwestern Ontario, 18-month mortality for older adults attached to community services was also higher. We also know that nutrition risk predicts health-related quality of life, and others have identified that it predicts institutionalization, poor emotional health, and social functioning. So it is an important part of our care of older adults in supporting them to live independently in the community. I'm now going to switch gears to frailty. Hopefully I've made the case that nutrition risk is common. We need to be looking for it because it can lead to outcomes that are negative and can impact the overall health and quality of life of older adults. So frailty, there are 2 different key domains or areas that we think of, or definitions I should say, for frailty. One is the phenotype model on the left-hand side, and the other is the cumulative deficit model. The phenotype model talks about the idea of shrinking, weakness, poor endurance, energy, slowness, and low physical activity as being indications that someone is frail. When someone has 1 or 2 of these conditions, they are pre-frail, and when they have 3 or more, they're considered to be frail. The cumulative deficit model looks more at the accumulation of a variety of things, or deficits, or risk factors if you want to call them that that can impact an individual's ability to adapt or deal with stressors in their lives. Regardless of either model that's used to identify frailty, there is consensus about what is frailty, and that's the middle oval in your slide. It's a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiological function that increases an individual's vulnerability for developing increased dependency and death. So frailty, you can see, has similar sorts of outcomes as malnutrition or undernutrition. And as I say, we're going to try to make the case that nutrition risk is something we should be looking at for individuals who are potentially also frail. So what is the prevalence of frailty in Canada? It's a little bit of a moving target yet, potentially because of the way we are measuring it or looking at it, but approximately 25% of Canadians are believed to be, over the age of 65, are believed to be frail. And so a variety of statistics here from different groups showing this, this prevalence in this age group. So pre-frailty is obviously more common, so similar to nutrition risk. We would expect nutrition risk to be common in older adults in the community, malnutrition not so prevalent. It's about 1/3 to 1/2 of people over the age of 60 is the estimate. It's also thought to be more common in women, and weakness seems to be the criteria or the component that's often reported. In terms of malnutrition and frailty, I alluded to the fact that we think there's an overlap between these two conditions. In fact, research has borne that out. First off, when we think of the phenotype model of frailty, it overlaps with what we think of as malnutrition. So weight loss, exhaustion, weakness, and slowness. Those various factors are associated with both being malnourished and being frail. Additionally, research has demonstrated that sociodemographic and other risk factors are similar for these two types of individuals, one being malnourished and one being frail. For example, social isolation. Additionally, the overlap in prevalence has been documented. We know that about almost 100% of people that are not frail are also well nourished. However, those who are 50% who are frail are also malnourished. There's been the estimate that malnutrition or risk of malnutrition will increase the risk of frailty by about 4 times. So we believe these two things are overlapping, and thus we should be thinking about not only identifying them in the same targeted groups of people, but also addressing them in terms of interventions similarly. I just wanted to make us consider how this could be potentially happening with respect to food intake specifically. And so we're going to make the case as well that nutrition might be a basis for frailty in some of our Canadian older adults. So low food intake, as I showed you at the very beginning of this presentation, is quite common in older adults. When people don't eat enough protein, for example, this could lead to weight and muscle loss, and that could then lead to poor appetite and cycling into frailty for an older adult. Alternatively, someone could lose muscle mass, for example, if they went into hospital for a short period of time and they were laying in bed for a few days. That could lead to muscle loss that then affects their appetite when they leave the hospital. That could then spiral into low food intake and over time could lead to frailty. And finally, poor appetite could be the actual starting point for this. People might have bereavement, for example, or not socially connected to others in the community, have low interest in eating, and that can lead to poor food intake and eventually muscle loss and eventual frailty. So there's many ways that we can come into this cycle of malnutrition, poor food intake, and frailty. However, we do seriously believe that there is a significant basis or root cause of frailty that is a component that is malnutrition or poor food intake. And this is one study here that demonstrates this likelihood. This is a 3-year study in older women, and they identified and watched these women over a period of time to see what happened to them in terms of function and frailty. Those who are in the lowest level or quartile of food intake in terms of protein lost 40% more muscle during that 3-year period than women that were in the highest quartile of protein intake, which was 1.1 gram per kilogram body weight. In addition to protein, micronutrient intake that was low in terms of vitamin D, carotenoids, selenium, zinc, vitamin B6, and B12 also predicted disability during that 3-year period. This gives strong evidence that nutrition might be a root cause, or at least for some individuals, for frailty. Further evidence suggests that we can treat malnutrition or undernutrition and frailty with similar diets that can impact the individual in terms of their outcomes. So a variety of research has been done around oral nutrition supplements. These are typically beverages that are consumed. Sometimes they're commercially produced or homemade. They tend to be nutrient dense, high in energy and protein and micronutrients. A variety of research, as I said, has indicated these supplements can promote weight improvement and affect mortality and morbidity. As well, they've been associated with reducing frailty indicators in older adults and improving nutritional status. Outside of supplements, we also know that high-quality diets seem to promote better muscle mass as well as preventing frailty. So specifically, protein is associated with skeletal muscle mass, and we've known that if we can promote food intake as well as exercise, this will improve quality of life as well as strengthen individuals who are pre-frail, preventing potentially falls and other negative outcomes. Nutrition intervention alone and in combination with cognition and physical activity has also been shown to improve strength and energy in older adults. So there is this definite benefit that we can have with treatment when it comes to diet and exercise to promote not only nutritional status but also prevent frailty. Falls are a common outcome of frailty and something we're trying to obviously reduce in our older adults living in the community, because this can lead to ER admissions, obviously, lengthy hospital stay that may then lead to long-term care placement. And so if we can prevent falls, we can perhaps delay some of that progression of aging that happens with older adults who are frail. Sarcopenia is the loss of muscle mass and strength, and it's a component of frailty. That component, when we think of the phenotype definition of weakness and slowness and exhaustion. So sarcopenia could also be a root cause of frailty. We also know that sarcopenia is associated with fracture and falls, and it may be more influential in men rather than women in terms of fall risk. Dynapenia, which is defined as strength only, not the actual mass of the muscle, basically talks about the quality of the muscle, may be more relevant for falls and the function of older adults. So we should be targeting the strength of the older adult and not just the muscle mass. We know that falls in the last 12 months are associated with decreased hand grip strength, which is a marker of potential dynapenia in older adults. So there is good evidence to suggest that the muscle mass and specifically muscle strength are linked to falls. So if we can improve muscle strength, that could lead to delaying some of these potential outcomes for older adults. We also know that falls are a potential outcome of nutrition risk. Now this data, as you can imagine, is very hard to collect, to find individuals that are at nutrition risk and identify falls. So much of the research is often retrospective or looking at what's happened in the past in terms of falls when people are identified to be at nutrition risk. So this one study that was done in Canada looked at a history of falls as compared to non-fallers and what were they like in terms of their characteristics, and this is a cross-sectional study. Those who were fallers were less active, they had more nutrition risk, poorer balance, lower extremity strength, and functional endurance. When looking at this in a multivariate way, they identified that nutrition risk still was an important predictor of a prior fall or fall history in these individuals, as well as low extremity strength and balance. Of course, this is cross-sectional, and we can say that perhaps falls lead to impaired nutrition risk, and that needs to be further looked at in terms of longitudinal studies. The subsequent study on this slide is actually doing just that. It looked at a longitudinal study, but it was looking at people who had, again, retrospectively reported a fall in the prior year. So nutrition risk was found in 10% of this very large sample in Taiwan. And when they came into the ER or identified that they had a nutrition risk, they actually saw that they had a fall in the prior year, and that nutrition risk was a predictor of that, an independent predictor of that fall. Other studies that have looked at falls and malnutrition have identified that people that come into ER and report falling in the past 6 months are often malnourished. Those who are fall are more likely to be malnourished as compared to those who do not, and malnutrition has been shown to be a predictor of falling. We do need more research in this area to demonstrate the true the prevalence of not only falls in people that are malnourished, and that malnutrition is the precursor to the fall, because it is very hard to detail out what came first in this situation. Now let's switch to thinking about how we can treat falls, considering what we know about nutrition risk and what we know about frailty. So the American Geriatric Society suggests that we should provide guidance around promoting fall prevention. This is one statement that they have. A strategy to reduce the risk of falls should include multifactorial assessment of known fall risk factors and management of the risk factors identified. And so this is leading us to our case again around nutrition risk screening and frailty screening in older adults that we're trying to make for you today. Neil and Matt, who did some research in Europe, identified that frail, malnourished patients post-discharge from a hospital, if they increased body weight, they improved their function, and this was done through using oral nutrition supplements and dietitian support. So showing that we can mitigate falls and improve function in older adults in this highly vulnerable group leaving hospital. So we should be putting into place things that identify those people at nutrition risk and then putting into place treatment to address it. So just to give you a bit more evidence around diet and falls and things we should be considering when thinking about treatment of individuals in preventing falls. So vitamin D is a well-known nutrient that has been linked to falls for some time, and we know that supplementation, there's been quite a bit of research in this area. We know that supplementation reduces falls by about 20%. The number needed to treat in terms of preventing a fall is 1 in 15, and number needed to treat would be 15 to prevent one fall. And we know that vitamin D improves muscle strength but not mass or power. So this is probably the mechanism that's working, and we talked about that before as being muscle strength, probably being the more important mechanism for falls. Vitamin D supplementation seems to be most effective when it's individuals that are actually deficient, and that has then led to the evidence statements that you see below on this slide, talking about 800 international units for those with a proven vitamin D deficiency. There's very good evidence that we should be doing vitamin D supplementation. And for those that are at risk of falls, who are suspected of being vitamin D deficient, we should also have supplementation, and that has fair evidence for that guidance statement. In terms of protein, there's been also a variety of research done, and one meta-analysis that we identified here on the slide for you by Saramac looked at various forms of protein supplementation, and they identified that whey, which is a very leucine-rich form of protein, is more effective than casein or soy for stimulating muscle synthesis and inhibiting breakdown with aging. And about 1.2 grams per kilogram per day are needed to actually benefit in terms of that muscle synthesis. And it's beneficial, especially when progressive resistance training accompanies that supplementation. We also know that protein seems to have its greatest impact in those who are actually at nutrition risk. So identifying, again, those individuals who are potentially going to be malnourished or are on the way to being malnourished and have nutrition risk at this point in time, that group should be targeted specifically for some of these interventions like protein supplementation. You're probably wondering about weight loss and falls as well. We know certainly that those individuals who lose weight over time tend to lose muscle as well as fat, but there is the issue of people that are overweight or obese, and does that group specifically have potential risks around falls and fractures? What we do know is that older adults who are obese tend to fall more. The question becomes, are they more likely to fracture? That evidence isn't consistent yet to say that they are also more likely to fracture. Certainly they have more padding that allows them to sustain a fall and not necessarily have a fracture. We do know that obesity with its pro-inflammatory cytokines could actually impair muscle and bone. But on the flip side, we also know that carrying more weight around actually leads to bone and muscle strength through mechanical loading. So it's a very difficult picture to tease out exactly what we should be recommending to individuals who are overweight or obese and are older adults. The evidence seems to suggest that if we do suggest weight loss for these individuals, we also promote it through a healthy diet, making sure there's sufficient protein and micronutrients such as vitamin D, and also progressive resistance training to support the muscle and the bone strength. So I'm going to turn over the slides now to Celia, who's going to talk a little bit more about screening.
Right, thanks, Heather. So for the next part of the presentation, I'm really going to be focusing on looking at how you can actually identify those that have that risk. So we've talked about some of those treatment patterns, but to be able to provide that treatment, we need to be able to identify those who are at risk. So with nutrition screening is able to identify those individuals who are at risk of malnutrition. So that can be on the spectrum of presenting with a few risk factors through to actually diagnosed malnutrition. And part of that is making sure that screening leads to diagnosis through to treatment. And it's not necessarily that just having that risk factor can be, it doesn't need to be having that risk factor can also lead to, you need to be able to address that issue. So screening is typically quite a rapid and simple process, and it's conducted by the first person that you would be seeing, so that frontline staff, typically a nurse. But the main point here is that it doesn't need to be a nutritional professional that's doing that screening. So for ethical screening, part of that is making sure that it's targeted towards the people that are in potential need of that assessment and treatment. So it's making sure that the right people are getting that screening so that they can receive the appropriate treatment. And it's identifying when there is a problem and making sure that that really does connect to a referral or a treatment algorithm. And an example of that is the integrated nutrition pathway for acute care. And although we won't go into that detail here because it's mainly focused on the hospital setting, we have a lot more information about that if you're interested. And also making sure that screening has a follow-up and a monitoring after or throughout the system. So now we're going to give you a chance to have your opinions. So what do you think the likelihood that you will start doing nutrition screening in the next 6 months? So very unlikely, likely, not sure if we're ready, getting ready, or definitely will be doing. So I can see lots of results coming in now. And we'll definitely be doing is currently in the lead, but there are results all across the board right now. So we'll just give that a minute to come through. Okay, well we'll close that for now, and I think you can see that. We'll definitely be doing is in the lead, but you can see that there's quite a range of responses coming through for the likelihood of actually doing nutrition screening in that practice. Okay, so we'll move on. So some of the main considerations in selecting a screening tool is that it has to be easy to use, and it can be used by frontline personnel, so people that are already part of the team or part of the practice, and incorporating it into existing systems. So you don't necessarily need to be creating a new pathway, but using something that's there already, easy to use, easy to collect that data, and it can be part of a general workup, etc. But the main component is making sure that the tool that you are using are appropriate for the setting that you're in and for the population that you're working with. So there's a lot of different tools that exist. Several of them have been looked at for their reliability and validity in specific settings. So making sure that you check that and make sure that the tool is right for your setting. And there's lots more information about the types of tools that are available. The one that we're going to be focusing on today is SCREEN. So this is Seniors in the Community Risk Evaluation for Eating and Nutrition. And with this tool, it can either be self-administered by an individual in the public, or it can be done through an interview with that individual. And the wording was developed by experts as well as seniors or older adults that were involved, making sure that the wording was right, the questions were there, and that it was easy to use. An abbreviated version is available, and I'll show you a bit more about that on the next slide as well. And it's been validated against dietitians' rating of nutrition risk, as well as test, retest reliability, inter-rater reliability, etc. And it can be used on a variety of platforms. And it is also free for anybody to access. There's a toolkit that comes along with it for how to actually incorporate that, or how to use it and build it into your practice. It's available in several languages, and we can send you the link for that as well if anybody is interested. So these are some of the items that are used on SCREEN, or SCREEN 2. So looking at weight change, skipping meals, swallowing or cooking difficulties. And as you can see, each of these questions would be really tied to an associated action or support that can be provided. So for example, if somebody is identifying that they have cooking difficulties, that person would be able to provide resources or information about support in the community that would be available. So if the person was at risk, that could include a referral to a dietitian, but additional support could also be provided to be able to address some of those more immediate needs that are coming out of or asking some of these questions. and the education that can come along with that as well. So if somebody had low fruit and veg intake, then there could be some education that was associated with that, and allowing for more immediate education or resources that are available for that individual. And just to note, the ones that are starred are the ones that are on the abbreviated version of Screen. So this is an example question from Screen 2. So how much fluid do you drink on a day? And it has specific examples that are listed below, so it's very clear what's being asked. And anybody that would be above 2 would be seen as fairly okay, that there's not much risk there and they're getting enough fluid. But somebody that would be a 1 or a 0 for the score would be at risk, and that's where you would want to have further discussions about what's causing that low fluid intake and what can be done about it. So on the overall tool, the lower the score, the more likely that the individual is to be at risk. And this tool has also been converted into a resource for self-management. So there's a website that is available for anybody to access, and it's designed so that it's very easy for older adults to use. They would go on the website, answer those questions, and then the results would come out immediately with a bit more education about some of their areas that they want to be taking note of, and as well as information for more information about those particular questions. So there's no score associated with this one, but it's just able to have that person that can self-manage and get some of those additional resources or information themselves. So most of what I've been discussing so far is focused on the nutrition screening side of things. But as Heather mentioned, there is a lot of connection between frailty and nutrition. And when we look at the frailty and nutrition tools, that you can see that there is overlap between those as well. And there isn't actually agreement on the way of measuring frailty or diagnosing frailty, but there is overlap in the characteristics for the screening or assessment tools. So the weight loss, functional capacity, weakness, cognitive status, etc. So based on that overlap and the real connection between nutrition and screening, or nutrition and frailty, we think that frailty or pre-frailty, so a couple of those conditions, as Heather mentioned, could be used as the justification or the trigger for screening, and be able to have that target population or a targeted approach towards screening. So some ways of looking at this could be using the 5 free criteria that we mentioned previously as a trigger that would lead to recognizing that nutrition screening needs to be done. The 7-point clinical frailty scale, which I will show you on the next slide, could also be used. So that involves some clinical judgment as well, but another potential trigger for nutrition screening. Some of the other key indicators, such as hand grip strength or 5-meter walk, might be options if they are available in your setting, or a more target for the segment of a population. So, for example, looking at anybody that's over the age of 75 because they're at higher risk for frailty or undernutrition. So, therefore, anybody that was in that category would receive nutrition screening. So still lots of discussion about how this would work in a variety of settings, and still looking into some of the possibilities here. So this is the clinical frailty scale. As you can see, ranges from very fit to terminally ill, and would making that call for whether somebody requires additional support. So for our next polling question, do you think frailty should be used as a trigger for nutrition screening in the community? And it's yes, no, not sure, it would not work in my practice, or it's already done in your practice. And we have a clear winner coming through right now. I think you can see that for yes, they think, or you guys think that frailty could be used as a trigger for nutrition screening. And a couple people saying it wouldn't work in their practice, but good to see. So I think those are still coming through, but we can pretty clearly see how that works. So for the next little part, component before we wrap up, I just want to focus on how you would actually, or some of the steps to think about for incorporating nutrition or frailty screening into the community. And part of that begins with raising awareness and understanding the importance of nutrition and frailty within the whole team. So having physicians and nurses and dietitians understand some of the issues associated with nutrition and frailty and what can actually be done about it. As we mentioned, screening does not need to be done by the professional who is going to be doing that treatment, but they can provide a bit of extra support depending on the tool. And for implementation of screening to be effective and sustainable, practice should outline a feasible and realistic plan. So we don't want anybody to jump right into screening everybody all the time, but starting small, finding that right tool, and then building up from there so it's becoming part of regular practice. So these are a couple of questions that you can consider before starting screening. So who will be doing screening or asking those questions? When is it going to be done? Is there a specific target group that you're going to be looking at? Which tool is used, and making sure that that's reliable or an appropriate tool for your setting. Who's going to confirm the diagnosis, particularly in the case of malnutrition? And when is additional training needed for some of that screening or diagnosis piece? How often should somebody be screened? And making sure that you know enough of those community services that are available so that when the need has been identified, you can provide that bit of extra support, even while still waiting for that referral to the next professional. So for implementing screening, there's an education piece that comes about that, as I mentioned, with the importance of screening for malnutrition and frailty, making sure that it does connect to an assessment and the referrals are in place so that once that person is identified, they can receive the treatment that they need. Working with the staff to make sure that they're comfortable with that overall process and know what they need to do for those individuals. Making it easy by embedding it into admission forms or however that works in your system. And using those reminders. So it's not just a one-off at the beginning, making sure having those audits and feedback to make sure that it keeps going. And again, celebrating those successes when things are working well. So in summary, we've looked at the prevalence of nutrition risk in Canada and some of the risk factors associated with nutrition, as well as how nutrition risk and frailty are connected and how that relates back to falls, as well as some of those multifactorial interventions and how the involvement of supplements, vitamin D, etc. And looking at how nutrition screening is able to identify those people that might be at risk and how we can connect that to the appropriate treatment. So that was all for me today, so we can open this up for questions.
Thank you so much. And we do have a number of questions that have come in through the chat box. So again, just a reminder, if you do have a question, feel free to type it into the chat box. That's a really easy way to participate. Or if you would feel more comfortable or prefer to ask a question over the phone line, after we get through a couple of the chat box questions, I'll give an opportunity if you would like to unmute your phone line by dialing *7 on your telephone keypad. And then we'll just ask that you dial *6 when you're finished so that you remute your line so we avoid background noise. But let's start with a couple questions from the chat box. All right, from Carol, what age group are you calling older adults?
It's great. So I use the 65 plus as my age group. However, Screen 2 is actually designed for 50 to 55 plus age group. I think the key is that when we see an individual perhaps starting to have changes in life that lead to potentially similar risks or challenges with respect to frailty and nutrition risk, that's sort of the segment we're talking about. So it typically is a family that doesn't have children in the home anymore, and that can be, as I say, as early as 50 or so.
Great question. All right, another one from Kim. Is the protein recommendation of 1.2 grams per kilogram per day based on the actual weight or the ideal weight for those who are overweight?
It's the actual body weight of the individual. And so I think that there's probably some debate about that, but when we think about older adults who are overweight again and challenged with in terms of potential pro-inflammatory cytokines that could lead to sarcopenia, I don't think we want to limit their protein. And so unless they have a kidney or renal disease where we might think about limiting protein because it could lead to kidney disease and kidney failure, that 1.2 is probably the better choice to use of their actual body weight.
All right, thanks for clarifying. So there were a couple questions about the Screen to link, the link to that tool. So I did send it out in the chat box, so you can grab it from there, copy and paste it, save it for your files. We'll also be sending out the link to that tool in the follow-up email, so you will have access to that along with the slide deck and the recording of today's webinar. That will all be sent to your email inbox in about a week, so you will have access to that, not to worry. All right, one more question, and then we'll open up the lines. So this one's from Carol. In the phenotype model, are there definitions or measures for each of the conditions described? So one can say an individual has the condition.
Yeah, exactly. There are, and that's being published more and more now that people are recognizing and trying to think about how we would actually screen for and diagnose frailty. So there's a variety of measures used. Hand grip strength, for example, is one that's commonly used for the strength piece. But there are key questions we're seeing in the research literature that are being used. I can't recall all of them right now, but there are some key ones that are being used.
All right, thank you. Okay, let's give an opportunity for anyone who would like to ask a question over the phone. So if you have a question, dial *7 on your telephone keypad now and just feel free to jump in.
I do see one question on the chat that I might answer if that's okay while we're at it, Lindsay. So someone asked the question, Heather McLeod asked, we use the M&A, any problems using this screen? Absolutely no problems with using that screen. M&A has been used in a variety of contexts, so everything from long-term care, hospital, through to community. So there's absolutely no reason why not to use it. I guess one of the challenges with M&A is that it's meant to be done by an administrator typically and not the older adult themselves. So in some scenarios it may be challenging to do it. I do know that a research group in Europe was looking at the validity of self-administration of M&A and how that compared to an administrator who's a health professional. So that research is just starting to see if it could be self-administered. I think one of the key things is to look at the questions on whatever screening tool you're looking at. And you'll see that there are differences that might lead you to using one versus another.
All right, thank you. Okay, so just want to give one more opportunity if anyone would like to ask a question over the phone, *7. Otherwise, we'll continue with chat box questions.
I see another question. Does the abbreviated version come with the Flintbox link? Yes, it does. And so there's a variety of versions there, French, English, and as Celia said, other languages as well. All versions we have are available for you there. If you want languages beyond English and French, you have to just ask the administrator of the site, and she'll send them to you as PDFs. But all the material is there for your use.
I do have a question.
Fantastic. Go ahead.
Yeah, I just wanted to know if the slide on the obesity could be reviewed again.
Sure. Go back to it, you mean?
Yeah, that'd be great. Yeah, just to run through that again.
I'm going to try to find it. And wait a minute. Should be the slide there we are. Okay. So this is pretty recent research that's coming out. I don't think we know all the answers to the question of whether or not we should be promoting weight loss in obese individuals, especially if they're osteosarcopenic. That's a new term that's out there where they're both osteoporotic or osteopenia and sarcopenia combined. That's a really challenging condition. We're just learning more about it and what might be available. I think for me, the blue font at the bottom is the most important thing. If you do advocate weight loss for individuals who are obese, make sure they're following a high-quality, nutrient-dense diet, so they're not limiting their protein or micronutrients that could lead to further sarcopenia and potentially falls or osteoporosis as well. And make sure resistance training is done with that weight loss so that muscle is retained and bone is strengthened. Does that help?
I think she's back on mute, but I think it helps.
Okay.
All right, so another question here from the chat box now. Regarding protein supplementation, has hemp been analyzed alongside with whey, casein, and soy?
Yeah, the whey and casein have had a long history in supplementation work with protein, and so there's a lot of research in that area. And hemp is a pretty new protein source when we think about it, and I know certain parts of the country there's some hot spots for use of it. I haven't seen a lot of research in that area yet, and so until we do those head-to-head trials of comparing hemp to whey, we won't know if it's at equivalent. I would consider any high-quality protein source is better than no protein, though. So whether it be soy, whether it be whey, casein, whether it be some of the ancient grains that are more complete, like quinoa, those will all be appropriate. More protein is better in my view, unless you, as I say, have a renal condition where you're concerned about excess of protein leading to renal failure.
And there was a related question also about pea protein for MPS.
Yeah, and so the same sort of issue. And so MTS, did you say? Sorry?
MPS.
Oh, okay. Yeah, and so certainly the same sort of scenario as the hemp, that I think there's lots of alternative protein sources that we're finding out more about, and they have other beneficial effects too, such as fiber, right? And so I think those are all options out there, but we haven't seen the head-to-head trials in the number that we would need to make a clear conclusion that these are better than whey or casein at this point in time.
All right, thank you for clarifying. A comment from Janice. Clients may ask their doctor for a vitamin D test called 25-OHD if they wish to have that tested. Absolutely, and I agree that that should be done, especially at 50 plus years of age. We should be getting our serum vitamin D checked. It's often lower than we anticipated, especially with our northern climes, so it's a great comment. And then a follow-up question from Carol. So she asked previously about descriptions of those measures and indicators. She just wanted to know if there was a place to find a list of those measures and indicators and descriptions. I read a lot, Carol, every day, but I can, if you email me, I can find you the paper that I read recently where I saw the different measures being used. It's just hkeller@uwaterloo.ca. I might not answer you today, but I will answer you. Fantastic. And maybe we could throw your email address up in the chat box if you're able. Or is it maybe if we have it on a slide? I'm not sure it's on a slide, but they're certainly welcome to email. Fantastic. Okay, a question from Rosalie. How many provinces will not pay for the vitamin D serum test? The assumption is that most of us are deficient due to living north. Yeah, I don't know the answer to that question. That's a very good question. I don't know the answer, unfortunately. Maybe someone on the call might know that. And certainly some of the recommendations are saying 800 international units, even when you're over the age of 50. Some are saying 400 if you're not deficient. I think the key is making sure we're getting some vitamin D, whether through milk products or other sources. It's very hard to get close to the DRI, though, after the age of 50 without supplementation. So a valid point that perhaps we supplement because we know we're probably at risk. The issue, of course, is not to do pharmacological doses of vitamin D, because with any micronutrient that we do that with, we seem to see negative side effects as well. Just a few comments that have come in. Alberta does not pay, and then a few people have mentioned that they know Ontario doesn't cover it except for very specific conditions. Yeah, so thank you for that information, everyone. And some of those conditions are osteopenia, osteoporosis, rickets, renal disease, malabsorption syndromes, medications affecting vitamin D metabolism for Ontario. All right, so I think let's give one final opportunity if anyone would like to ask a question over the phone, just because we are coming to the end of our presentation today. So if anyone would like to ask a question, please dial *7 and ask away. All right, so I think that that might be it for today then. We don't have any more questions in the chat box, and no one's feeling brave enough to ask over the phone. So thank you so much, Heather and Celia, for that wonderful presentation. It was really useful information, and I think it's very promising to see how many people are interested in nutrition and frailty screening, and how many organizations seem to be moving forward with it even before this presentation. So thank you. Very well done. Now I would like to ask our participants, please don't close this window just yet. If you could wait until you've been redirected to the Level 3 lobby screen. When you see that screen, it's safe to close the window, and a brief evaluation survey will launch in your web browser. We'd appreciate if you could take a few moments to provide some feedback so we can continue to provide high-quality webinars. For more information about the Fall Prevention Community of Practice, you can visit Loop at fallsloop.com. Loop is a free online communication platform for fall prevention practitioners. Again, that's fallsloop.com. All right, thank you everyone. Thank you to our presenters. Thank you to our participants. Thanks Marguerite for helping with the technology. We'll see you next time.